So we're going to talk about TIL therapy. So tumor infiltrating lymphocyte therapy. So Dr. Dranka is going to dive into this more deeply, and I don't want to steal her thunder, but it is necessary to set the stage for my talk. So 1975, this one drug, dacarbazine, was approved for melanoma. It was the only drug, not very effective. 1995, interferon was approved, and then these other drugs that are attempting to rev up the immune system. So we're thinking about the immune system here, not just a poison that you give to kill fast-growing cells, but to help your immune system. But this one's really toxic. To give this one, which I did, you admit the patient to the ICU to give the drug, to give you an idea. And this one is the year interferon that we talked about. And then you can see what happened here. It's just absolute and utter explosion. And all these FDA-approved drugs, and it's just coming and coming and coming. This is a patient who had clearly advanced as a PET scan. Every one of those spots essentially are melanoma, and they received on trial immunotherapy. And so this is not the result everybody gets. I don't want to give any kind of false hope that everybody, but obviously really, really impressive results that we would never have seen a decade earlier. And hence the Nobel Prize to these gentlemen for developing immunotherapy. So this is a slide that shows melanoma, and it's stained with our standard H&E. And so you're really looking, the pathologist, to focus on the melanoma cells, right? Diagnose the cancer. What we haven't been focused on until recently is if you put a different dye on there and you look for the immune cells. And you can see that top patient, if they both had the same thickness in melanoma, those immune cells not really revved up, not really attacking that melanoma compared to the bottom one. So these are TILs. These are tumor infiltrating lymphocytes, your body's immune cells identifying, seeking out, going after, and trying to destroy the melanoma. So just one slide step back. So this is what we call a hematopoietic stem cell. That means it can differentiate. It creates a lineage of all these others that differentiate. That's in your bone marrow, that these different types of cells are made. And it can go down at this early stage, at the first division, it's going to go down this arm or this arm. And if it goes down this arm, you make things like platelets, you make things like red blood cells, you make things that are necessary, and platelets clot blood, you make certain macrophages. If you go down this lymphoid stem cell system, then you make things like B cells, those make antibodies. B cells make your antibodies, and then T cells. T cells, there's lots of, we learn now different T cells. We used to just think of as one bucket, but there are T cells that suppress things. There are T cells that cytotoxically kill things. And so these are T cells, and they're attacking that cancer cell. So T cells are white blood cells. They're made in the bone marrow, and they've migrated from the blood to the tumor. Patients with cancer have TIL cells, but in some cases, they're not enough to win the battle, to fight the cancer. So we make cancers, which our body recognizes and take care of before we ever know it. We have genetic abnormalities being created all the time that those cells don't proceed on because they get wiped out, and that's a typical pattern. But sometimes cancer does develop, and then it's a battle between your immune system and the cancer. So these T cells, they can become exhausted, literally. If we test them in a Petri dish, they're worn out, they're tired, they're fatigued, they're not able to keep fighting. So TIL therapy is the first therapy to be approved for solid tumors, first cell-based therapy. So you may have heard of CAR-TIL, CAR-T, and that's modifying T cells to attack leukemias and lymphoma. So that's blood tumors. That's been around not too long, but really revolutionized how we take care of leukemia, lymphoma. This is T cells now being used. This is a living drug. So when we give a patient their drug, it's a bag of live cells. We're giving them a live cells to fight a tumor. It's living therapy. I mean, it's really just absolutely fascinating to give living drugs to people. And we use the patient's own T cells. We don't have to modify them like CAR-T therapy. We have to modify things to recognize leukemia, lymphoma, because we take out the patient's tumor, and I'll dive into more detail. We're not taking out the tumor to cure them. It's a means to an end. We're taking out a tumor to make T cells. So it's not a treatment in itself, my surgery in these patients. It's to take out a portion of tumor I can do safely with low morbidity, low complications, send it to a lab. The TIL cells, the tumor infiltrating lymphocytes, are taken out from that tumor. They recognize the melanoma. They've been trying to fight the melanoma, but they're exhausted and they're outnumbered. So when it goes to the lab, they get enriched and they get propagated, and we give back now 7.5 billion of these T cells to do their job on the patient. And that gets given back to the patient. So this started out at the NIH, 1988. This is a publication, the first publication showing this patient who had a dramatic response to TIL therapy. You can see these big white lung spots here. Didn't have PET scans. This is how we saw the melanoma. Obviously, there was other melanoma in the body. If we had PET scan, we would have been able to pick up. But you can see this is 4 months later, and those are all gone. And so this is a single case report, very promising, 1988. This is a patient, their liver riddled in 2003, and this is after now 12 years later with TIL therapy. So again, I'll just stress that this was just approved now in February of 2024, February 2024. So that's about 40 years. 40 years of this idea, this research, and now FDA approval. There's no industry in the world that's going to fund 40 years of research to see if a drug gets approval. All this was done at the NIH prior to the recent FDA approval. Now, industry has come in, and industry has made this scalable because it was so labor intensive to do each individual patient that this was not able to be populated unless you went to the NIH or a few other centers. So industry has now made this commercializable where we can deliver it in a scalable manner. And so this was one of the first studies. And just briefly, this is a waterfall plot. And so we take everybody who's got a melanoma, stage 4 disease, and we put them on their baseline imaging is 0. Whatever they have is 0. If they have 5 lung mets, 2 liver mets, that's 0. And then we give them therapy. If that shrinks, then this is their response. So that if you're dropping on the waterfall, this is your response from no response to 100%, the tumor completely went away. And if you're going above, that means from your baseline when we gave you therapy that cancer actually grew. So this was a large publication, relatively large. 78 tumors were resected in 78 patients. Only 66 received TIL, and that drop-off is because sometimes we can't make enough of the TIL cells to give back. So they had the surgery, but we couldn't enrich it enough. So unfortunately, that didn't go on to deliver the TIL. So that's obviously disappointing. Really important to note that all these patients had 3 prior therapies for their stage 4 melanoma. So they had stage 4 melanoma. They received the best known therapy. Maybe it worked, but they recurred. They received the second line. Now you're on third line. So now on average, they've failed 3 other things. Now we're giving TILs. And this is the response. So you can see all these people in some way responded. Pretty dramatic after failing 4 other best treatments. And this trial further, once that was so enticing, now they took it against what's currently was at that time the best therapy. If you failed immunotherapy, then you went on to a different immunotherapy, ipilimumab. And these patients certainly, half of them got responses, maybe half didn't. Pretty good response rates. But head-to-head comparison, randomized trial, TIL, you can see the difference. I mean, you can just look at that graph and say that many more responses. So that was clearly promising. And not only that, the TIL therapy, the people who did respond, they typically had a long tail, meaning if they responded well, then the cancer stayed away long-term. So with all this promising stuff, this was ultimately the trial that got FDA approval. This 153 patients who received TIL. Again, on average, they had failed 3 prior therapies. And the overall response rate is 30%. So I don't want to make it sound like everybody responds because everybody doesn't respond. 2/3 of patients still don't respond. But if you take a group of patients who have stage 4 disease who failed 3 best therapies and are trying something else, there's not much else. And the response rates of those are pretty close to 0. So a 30% response rate after failing 3 lines is really impressive. So the question becomes, what if you give it second line, first line? What would the response rates be? So you can see overall response rates are 31%. And importantly, if you had a response, 40% of those patients maintained that response 1.5 years out. And that top slide is what is most impressive. It's the duration of response. Again, if you were one of the responders, if you didn't recur in about 1 year, long-term, you didn't recur. And this is a one-time treatment. And if you get a response, you're likely to get a really, really good durable response. So as noted, FDA approved this as a result of this in February 2024. We were primed and waiting for that. We kind of had seen the stuff at the meetings. We had kind of been aware what was going to happen and trying to read the tea leaves. So we treated our first patient the following month, February 2024. Very complicated process, as this slide will show you. So this is the process. This is a journey the patient takes and the cells take. They're on 2 different journeys. So we meet as a team. We discuss, is this patient an appropriate candidate for TIL for a number of reasons? It's decided they are. And then they go to surgery. And the surgery, again, is not the treatment. Usually surgery is the treatment. The surgery is purely a means to an end where we're taking out a tumor, one of the tumors, if they have lung mets, liver mets, they have a nodule, a lymph node on the arm, we're taking out the tumor where we think we can get enough cells at the least morbidity for the patient. We don't want to do an operation, then the patient has complications, and then they can't get the TIL therapy. So we're trying to do the least aggressive surgery. And so if we take the TIL journey, so now we're going to follow the cell. So me or one of my colleagues remove the tumor that we think is a safe tumor to remove and going to give us enough lymphocytes. And then on the back table, it's a fancy word, we prosect it, meaning we take off all the fat, all the necrotic tissue, and we take the viable tissue. It has to be a large enough sample. We put it in this medium. It goes off to a lab. It gets shipped to the Navy Yard. That's what it used to be called, the Navy Yard in Philadelphia. I don't know if you guys are familiar with Philadelphia. They have a 136,000 square foot facility, massive facility, the largest in the world. And this is a commercial company. So everyone is getting their TIL therapy done this way. And this commercial lab now is made this scalable, where they do all that stuff the NIH was doing. And they take those cells and they enrich them, they expand them, and they put them in this cryopreserved bag. It's frozen, and it's shipped back to the hospital. And now on the patient journey, so after surgery, the first thing is obviously the patient has to recover. We want to do a surgery as least aggressive as we can so the patient can recover uneventfully. Meets back with medical oncology, gets admitted to the hospital. Before the TILs arrive, about a week before the TILs arrive, they get a lymphodepleting chemotherapy. That means a chemotherapy to wipe out their regular T cells. So that's a week in the hospital. They get this one-time infusion of these live cells, and then they get a boost of this drug called IL-2, which can be a toxic, but that really stimulates the T cells to wake up and go to work. And then they recover and ideally go home. So for the patient, -8 would be 8 days prior to receiving the TIL. They come to the hospital, they get this chemotherapy to basically wipe out their white cells so that T cells will engraft and be the primary T cells. It's called lymphodepleting is a fancy word. And then they get the TIL infusion and they get this IL-2, this dose of a therapy that really stimulates the T cells, but it also can have other kind of cardiopulmonary effects. You can get fluid on your lungs. You can have some toxicity from that. So they're monitored very close. And if they get, significant enough toxicity, then it's stopped. But we give a minimum dose there. You see the maximum is going to be 6 doses. About 10% of the patients will have significant side effects that they actually have to go to the ICU. So it's not for the faint of heart. They are monitored and then discharged home. The beauty is it's a one-time therapy and all the toxicity really happens in that hospital stay. So you need to be fit and durable enough to go through that. But if you do on the back end and it works, then the results have been very promising. So everybody gets what we call neutropenia, your white cells knocked out, because that's the intent. Typically, we think of that as a complication of chemotherapy where your white cells got too low, but this is intentional neutropenia. About 30% of patients will get complications from the IL-2, and about 10% of them, like I said, will require a short stay in the ICU. All of that stuff is reversible, is the beauty of it. It's just a patient I operated on, melanoma throughout the body, but this was the most accessible, lowest risk melanoma to remove, was the lymph nodes there in the groin. Took a sample, prosected it, put it in that media, shipped it off to the lab, and no, I'm not gonna be able to go back. I'm not smart enough to do that. And then in the lab, you saw that Petri dish with all these other TIL cells that were growing that they're gonna use to give back to the patient. So who are our candidates? Patients with stage 4 advanced disease that are not amendable to resection of that disease. They had to have failed at least one line prior therapy. So right now, TIL is not approved for first line. They have to have failed standard best practice first line immunotherapy because immunotherapy is very effective. And you need to have at least one or more lesions that we can collect. We have enough tumor that we can make TILs out of. And what else? Low risk surgery. So doing a big pancreas operation, doing something really radical is not the appropriate candidate to do this for. Need to be medically fit. It's a tough therapy to do for 2 weeks. It's tough on the system, so has to be a fit patient. What are the positives? It's one-time treatment. About a third of the patients who have failed everything else respond. And if they respond, most importantly, it's often durable. What are the challenges? It's expensive. It costs about $500,000, a $500,000 treatment for each patient. It's labor intensive. You need to go to a highly specialized centers. Most centers are not offering this. It is toxic to everybody, but it's a short-term toxicity. So there's limited patients who are eligible for this right now. Sometimes, I said, unfortunately, despite best efforts, not enough TIL cells are made, and that's just the reality of it. Although 1/3 have a response and they're impressive when they do, 2/3 unfortunately don't respond. So we still obviously have a lot of work to do. So what's the future? We're going to be treating more patients with less toxic therapy and having higher success rates. How are we going to do that? Potentially, there's studies going on seeing if we can be less aggressive with that chemo depletion. Do we really need to do the full 8 days? Can we do something less aggressive? The other area is that IL-2. There's other interleukin agents, 15 is one of them. So there's trials going on to see if we can give a less aggressive interleukin to stimulate the T cells that don't have those side effects of cardiopulmonary that the IL-2 does. There's trials looking at, can it be first line? If it works so well as second, third, fourth line, how well would it work as first line? And then it is being looked at combined with other therapies. All this research is going on. What if we get TIL plus some other drug? And finally, for other disease sites. TIL will be eventually, in my prediction, be used for other diseases also in the future, not just melanoma, as was alluded to earlier. Yeah. So I'll stop there. Happy to answer any questions. Thank you.
Thank you. Test. Can you hear me? Thank you, Dr. Jakub. We have an online question. What is the typical time frame for the patient for when the tumor is resected until readmission for the TIL therapy?
Yeah, I would say it takes a minimum of 3 weeks to make the TIL. Right, Jenny? 3? Yeah, no? 4? 5?
Somebody go.
4. Jenny says 4. 4 weeks. So I'll repeat the question one more time. Can you come a little closer to the mic? Gotcha. Like an off the shelf, like any other drug. Yeah, good question. I would say maybe in the distant future, but right now, your immune cells are your immune cells, so they're going to attack. If you give it to someone else, like a transplant patient, they have to stay on immunosuppression for the rest of their life because you have a graft versus host response where your white cells would be attacking the patient's body parts. So yeah, there would have to be some significant advances to be able to do that. The alternative would be someone on lifelong immunotherapy, which is not going to be a good option.
So I'm trying to put this into context. So that's just a lay question. I did have dinner with President Carter years ago after he had survived through what at the time was a breakthrough, immunotherapy, cancer of the brain. So could you put the therapies we just talked about, TIL, in context with that particular protocol?
Yeah. So Jimmy Carter, metastatic brain cancer, melanoma to his brain, which would be 3 months, 6 months survival. At that time, immunotherapy was not approved. He went on to immunotherapy, and 20 years later, recently passed. So he was getting tomorrow's treatment today, if you will, and that's the way we think of research. I would say immunotherapy was a complete game changer, and I would say TIL therapy is similarly for melanoma. I would set those two as pretty similar on the impact they're having on the field of treatment of cancer. Yeah.
Is in order to select a patient for this therapy, does there need to be the presence of TILs on pathology prior to being a candidate, or is that confirmed in some way? Is that necessary, I guess?
Yeah, so it definitely is necessary, but no, the slides I showed you were from a skin melanoma. So the TIL therapy that we're going to be harvesting is from lung, soft tissue, and we don't have a way really to assess that prior to the surgery.
And follow up to that, would with this amazing, I mean, super amazing opportunity with TIL therapy and the advances in immunotherapy, do you see that changing the approach to sentinel lymph node biopsy and the kind of the disruption since we're kind of engaging the immune system? Is there, I know that's kind of the premise behind neoadjuvant, but
Yeah.
you see that shifting as a whole?
Yeah, so there is definitely a shift in the philosophy. It was interesting. I was reading an article uh, last week from 1952 by a physician who was talking about, in his experience, it was from a medical journal. In his experience, the lymph nodes are supposed to be a place to fight cancer, but in his experience, they are the place that grows cancer. It was a very interesting, you look back at some of these old articles, and it's really interesting that they're hinting at things now that we're kind of realizing. So now we're thinking more and more that the host immunity, the lymph nodes, the more we can keep them in place, maybe the more they can do their job if we can stimulate them to do their job. There's certainly, to cure people, we have to remove lymph nodes in some patients. But that goes back to the study that I'm pitching, which is, if you have the lymph node in place and you give the immunotherapy for 2 cycles prior to surgery, as opposed to do the sentinel node biopsy first, and if there's a little bit of cancer in there, you've taken it out, maybe treating the patient before. That's theory, that's hopefully research, but we are more and more appreciating the role the lymph node and the immune system certainly play in fighting the cancer. Yeah, great question.
Okay, we have a few online questions, and I think this is a great one. Is TIL equally effective for ALM, mucosal, or uveal melanoma?
I don't know the answer to that. I think we're going to, Jenny, do you have any, or should we ask Roxana? Yeah, great question. We're going to pause on that one. I don't treat uveal. I have not. Uveal is unique and that spreads to the liver. And we have some very exciting studies for uveal melanoma being able to, instead of treat the whole body, infuse chemotherapy just into the liver to try to treat those liver mets. So that's something really exciting in uveal. I'm not aware of any TIL performed for uveal, but I don't know the answer to that. Right now, we don't discriminate acral versus superficial spreading nodular to give TIL therapy. I don't know if people have published on different response rates based on the subtype of melanoma.
If immunotherapy caused your body to attack itself after one treatment, is TIL an option if the melanoma cancer returns?
Yes. Yeah, I would say yes. We definitely see a lot of toxicities from immunotherapy of, as you autoimmune kind of stuff, and those patients are candidate for TILs if they have progression or recurrence.
At which stage?
Stage 4. Yeah. Yes. Yeah. No, I would say for stage 3, barring some situations, stage 3, we typically give immunotherapy. And if you have clinical stage 3 disease I showed with pretty bulk, we get pretty dramatic responses. So our typical approach is, I think we have very good treatment approaches for clinically stage 3. We give immunotherapy, and then current standard right now is operate. There's a trial coming out of Australia where we're looking if the patients who have exceptional responses not operating, just doing the immunotherapy alone. But right now, the current best practice is if they have clinical nodal disease, give an immunotherapy, get your best response, then operate. And then TIL would be down the road if there was future recurrences.
If you have stage 4 and it's the immunotherapy that's causing you, it's working, but
Yeah.
yet the therapy itself is more problematic. Are you a candidate for TIL? If you can then get healthy enough, I guess, to undergo the surgery.
Yeah, I think that would be the medical oncology decision of, balancing that toxicity versus response rates. And I think that would be an individual. I don't think there's a blanket answer for that, but I think that would be an individual provider discretion.